Welcome back to Did You Know, a podcast by Partner Veterinary. In this series, we dive into everything veterinary medicine and everything partner. In each episode, we tackle some of the most common questions we hear, from HR to emergencies and everything in between. If it happens at Partner, we'll talk about it. Few conversations are harder for a pet owner than hearing your pet has cancer. Suddenly, you're faced with unfamiliar terms, difficult decisions, and questions about what the future holds. In this two-part series, Partner's board-certified veterinary oncologist, Dr. Kyle Renaldo, joins us to guide pet owners through the cancer journey, from diagnosis and treatment to quality of life and end-of-life care. In part one, we discuss what happens after diagnosis and what to expect during your first oncology appointment, how treatment plans are developed, which cancers are most responsive to therapy, and the realities of chemotherapy and radiation. Whether you're navigating a diagnosis now or want to be better informed for the future, this episode will help you understand what lies ahead.
I'm Dr. Kyle Renaldo, a medical oncologist with Partner. I grew up in Tampa, Florida. I was there for 25-ish years of my life. And then I went to veterinary school in Kansas State. The reason I went to Kansas is one, it was one of the few places I got in, and two, they took a lot of out-of-state students. I ended up meeting a lot of really cool people there and enjoyed my time there. And then I did some additional training, like internships. I did my rotating internship at University of Georgia, and then my oncology internship at Blue Pearl in Tampa, Florida, where I grew up. And then I did my residency at the Ohio State University and finished in 2018. And then when I finished, I was working in Annapolis for the last 7.5 years. And then I chose Partner because I really like the culture here. I think people really treat each other really well.
Dr. Renaldo, welcome to Partner, and thank you so much for joining me today. Today, we're going to talk about understanding life during chemotherapy and then the journey forward with veterinary oncology. I wanted to start by just asking you, when a pet is diagnosed with cancer, what does the initial conversation with the family look like, and how do you help them understand their options?
I would say the initial conversation, I think one of the things that disappointed me in veterinary medicine, probably my entire career, even go back to when I was a student, and it's still this way, is that oncology for veterinarians is an elective course. So when you go through clinics, you're not required to take oncology, which seems silly to me because we see cancer all the time.
It's prevalent.
It's a rapidly growing specialty in veterinary medicine, and it's probably one of the most common diseases pets have, both in cats and dogs. And so not a lot of some veterinarians don't have exposure to onco until they're out in practice. And so I think one of the key points up front with clients is just kind of explaining, this is what your pet has. This is what your cat or dog has been diagnosed with, this type of cancer. Let's talk about what it is. Let's talk about, depending on what's left to do diagnostically, what we can do diagnostically to gather more information to help you make a more educated decision for treatment. And then let's talk about treatment options. So what's out there? I always would say for oncology, to simplify it, we probably really have 3, maybe 4 major options: surgery, radiation, chemo, and then the fourth is usually immunotherapy, but that's not always existent depending on the type of cancer. So I usually myself will go through this is standard of care. This is minimally what we can do. And then if an owner financially cannot afford standard of care, these are intermediary options that we can consider where you're doing something. It may not be perfect, but it should still help. And it should still be an important treatment for your pet. So I try to give them as many options as I can. I don't tend to be black and white. It tends to be more of shades of gray.
And I imagine when you have a pet that is diagnosed, having those options is really welcomed because it's probably a very overwhelming experience for an owner.
Yeah, and I've been on the other side of it in human medicine. My mother has cancer, so I've seen the conversations in people, and it's not the same. Like it's a lot of like, especially in the United States, it's a lot of like do. Like we're going to do this, we're going to do that. There isn't really a choice sometimes. It's more of this is what we're going to do and this is how it's going to go. The other thing I usually talk about is prognosis. One of the things I would say is that's never set in stone, but we have numbers that we can quote. They're not perfect and they're often averages that vary a lot, but at least people can have an idea of what they're getting into up front. You don't get that in human oncology unless you ask for it. They don't tell you survival time. You can look it up, but it's not like a part of that conversation at all. So I try to have that conversation too, because I feel like that's lacking sometimes in our own lives. So
yeah. How do you decide whether chemotherapy is the right path for a pet? And how do veterinary oncology protocols, again, differ from human ones? We've kind of touched upon this, but
yeah.
how do they differ?
To answer the second part first, in terms of how they differ, I think our focus is more based around quality of life. So a lot of it is based on trying to eliminate or really minimize side effects because they can't really make the decision for themselves. We have to make it for them. And so it's not benign. There is usually about a 15 to 20% risk of side effects with treatment, but compared to human medicine where it's over 80%, it's a lot better. We don't push them as hard. There's a protocol in non-Hodgkin's lymphoma and in canine lymphoma called CHOP, CHOP, and it includes multiple chemo agents. In people, they give all of them on the same day. In vet med, we do it like one at a time. One drug once a week. I was privy to a lecture last year at our annual conference, and a human oncologist was talking about treating resistant lymphomas in people, and it was a really interesting lecture. But he made this comment that if we pushed our patients more, we would probably accomplish cure more often. And he called the type of chemo we had palliative, and people kind of got offended by that. And I actually thought that was a really accurate statement. Because we don't push them as hard, we sometimes don't accomplish cure, but I think a lot of it is based around quality of life. I haven't met an owner that has thought that's not the goal. Like every owner I've ever spoken to, that seems to generally make sense.
Yeah.
Yeah. And I'm sorry, what was the first part of the question?
Oh, yeah. How to decide whether chemotherapy is the right path for your pet.
Sure. Depended on the cancer we're treating. Some cancers, chemo is the treatment of choice. Sometimes it's adjunctive, like you need surgery and then you follow with chemo. There are some cancers where chemo is actually not the appropriate decision. And there's some cancers that don't even require chemo. So I think it just depends on what is in front of us at the time and whether it makes sense or not. I think we give a lot of chemo. There's a lot of chemo for a lot of diseases, but there are some diseases like melanoma that sometimes immunotherapy or some mast cell tumors like surgery are the better options over chemotherapy.
What would you say are the cancers you most commonly treat and which tend to respond best to the chemotherapy? You did just touch upon that again.
I would say the top 4 that I see are lymphoma, osteosarcoma or primary bone cancer, melanoma, and then mast cell tumors. And mast cell tumors are a veterinary specific disease. We don't have anything comparatively in human medicine to them. So they're and they're not even the same between dogs and cats. So it's just such a weird disease. The other big cancer we see, I would say the 5th one is hemangiosarcoma, the blood-borne cancer. A lot of owners experience that because that's the bleeding splenic mass or the bleeding heart mass. That's more of an acute emergent kind of situation. So those cases are pretty common too, particularly in emergency settings.
How do families weigh the cost and commitment of treatment against the potential benefits?
I think a lot of it is just going through options and giving them the information financially of like, this is standard of care and this is what it costs. This is intermediary options and this is what they cost. And this is more palliative care and what it would cost if you did nothing else. But usually nothing is not nothing. It's something. I think they'll often like weigh that against prognosis. I think talking about prognosis really matters because I think some owners will look at, everybody's different. I've had owners that look at like, a year is not enough for them. And I've had some owners who think, oh, if I can even get 3 months, that's enough time for me. So everybody's different.
Right.
But I think they just weigh like, if I put in this much and I'm potentially going to get this amount of time, is it worth doing that? And I think that really factors into decisions.
One of the biggest fears pet owners have is that treatment will make their pet miserable, that the quality of life will diminish. How do you address this with owners when they're trying to make that decision?
I talk about it a lot in my initial conversation. I try to have that conversation up front to set expectations too. I think it's better to talk about it up front than when there is a problem. That way people are prepared, because it'll also let them know what they're looking for at home if there's a problem. Generally, I had mentioned earlier 15 to 20% side effects. Categorically, we look for a lot of stuff. I think hair loss in veterinary medicine is really rare unless you own a poodle dog. I think that GI upset, decreased appetite, lethargy, less likely vomiting, but nausea and diarrhea are there. Not super common, but there. And I think drops in the white blood cell count that put patients at risk for secondary infection is there. One of the dogmas, I would say, in our profession and things that are believed but not always true is I don't think the patients we treat are immunosuppressed. I think they can be myelosuppressed. And I do think there's a difference. Like, I think when we give chemo, I think their white blood cells are functionally normal, but if you take all their cells away, then they can't fight off infections. So it's not necessarily that they're not doing their job. It's just that there's not enough of them to do the job if they're really low. So I think a lot of the patients we treat, the risk for immunosuppression is really rare. So I think that's one thing we don't commonly, versus like, I can't say how many patients I've seen through medicine that are on drugs like Atopica or cyclosporin or think those drugs immunosuppress patients. So if they have certain diseases that require those meds, I think those are more likely to immunosuppress patients than patients on chemo.
One of my next questions was, how does chemotherapy compare to in pets to humans, which we have talked a little bit about, but that's one of the big things, right? Because humans, when we go through chemotherapy, we are immunosuppressed.
Yeah.
So that's a very big difference then.
It is. And I think a lot of it factors into how hard we push them. So I think people get pushed a lot harder and see a lot more drugs. And because of that, there's so much more risk for infection. The medical term for a drop in the white blood cell count that leads to infection is a term called chemosepsis. So that's really common in human medicine. I think there's probably, I don't know the statistics, but I'm pretty sure you could make a strong argument. It's probably one of the leading causes of death through chemotherapy in people. And certain people that are higher risk for it, if they're already immunosuppressed, or if they have a history of, let's say, like pneumonia or some kind of chronic infectious disease, they're going to be at a higher risk of getting septic versus someone who's completely normal. Our patients, I think the risk for chemosepsis is really low. It's usually like less than 1%, but I think a lot of that is because we don't push them as hard. But I would always say, anytime you treat a patient, the variability of tolerance is there. Like, there's patients where you can take two dogs of the same breed, same age, same background, and they'll tolerate the same drug at the same dose completely differently. One dog may have zero side effects. The other one may have more than that and require changes in their protocol or changes in their dose. So I think we run into issues. We try, because quality of life is a major factor. We will like reduce doses, we will alter drug protocols, we will add in more supportive meds, we may do a lot of different things to try to offset problems. So I don't think, if I, as a pet owner myself, I wouldn't tolerate GI upset or major problems. Like if my dog is vomiting or having diarrhea all the time, that's just not fair to their quality of life. So why would I expect an owner to tolerate that? And so I also don't want people giving like 30 medications. I can't give 30 medications. I think it's really hard for me to ask somebody else to do that. So like, what's essential, what matters? Like, if we can reduce it and there's less problems, I think they're going to be happier overall.
What side effects should owners realistically expect, and which are more manageable versus more serious? When do you know, okay, this isn't working and it's time to move on?
Most diseases we treat have measurable disease, particularly, for instance, like with lymphoma, a lot of dogs will have big lymph nodes, or they may have something that you can measure, and whether those shrink over time or disappear versus if they're not really changing can dictate whether something is working or not. Because if it's working, they should go away. And if it's not working, they're not really going to change. I think one of the hardest things sometimes in cases is to tell the difference between disease and chemo side effects, particularly if the disease is GI based. So if a patient comes in for vomiting and diarrhea, and that's from their cancer, and then you're treating it, and then they're having vomiting and diarrhea, it's really hard to know which one is it.
Yeah.
I think a lot of it comes down to timeline. Like when you treat, if you're looking for GI upset, it's about 3 to 5 days post. And it's going to be those simple things like decreased appetite, which can be a symptom of nausea. lethargy, vomiting, diarrhea in a 3 to 5 day timeline post chemotherapy. If you're seeing stuff more than a week post or even acutely, it's probably more likely something else, or it's their disease versus it being chemo. I would always say the further away you are from chemo, the less likely it is. But every chemo is different. I've had cases where I treat them and the drop in the white blood cell count is about 7 days post, and it causes similar symptoms like lethargy, not eating if they're really, really low. And then you're looking for fevers and evaluation if there's a concern. But sometimes people say 7 days. It could be 6, it could be 5, it could be 8 or 9. It's not always 7. And so I've had patients that drop at like day 9, and you're like, why are you dropping later than I think? So it's not always this. The GI stuff sometimes is. I have a dog I treated, a patient of mine recently, who would get treated every 3 weeks, and his GI signs started 7 to 10 days post treatment, not 3 to 5. So I used to treat him in that timeline, but it took me, I had to figure that out, that was what it was. I had to troubleshoot around, like, this doesn't seem to fit, but when I treat it, it's better. And so, and then going forward, every time he hit that timeline, we would just put on anti-nausea, anti-diarrheals, and he had no other problems after that. So it helped a lot. But some patients, those numbers vary, but that's the general timeline for side effects. I try to address side effects up front in my conversations with clients. I will say most of the time, if I don't mention anything and then someone sees something, it's probably because it's not a side effect. But drugs are drugs. Sometimes you see weird things. I'm always willing to say, could this be drug over something else? But I always find some of the weird stuff people talk about or go, could this have been related? There's a lot of times where the answer is probably not. So like if you give a drug that causes GI upset and suddenly the patient starts coughing, I don't know if the coughing has anything to do with the chemotherapy. That may be something completely different. If a patient had a history of diarrhea before ever getting treated and consistently has diarrhea through treatment, you have to wonder if that's related to whatever was causing it in the first place. Dogs and cats have other problems. There's primary GI disease like inflammatory bowel disease or irritable bowel syndrome. There's respiratory diseases like heart disease and bronchitis and stuff like that. So I think sometimes drugs do weird things, but it's not super common. So most of the time, the major things are GI and a drop in the white blood cell count.
Okay. And when you talk about the treatments and the time frame, what are we looking at? You know, when you start treating a dog or cat, when they have their first treatment, the second treatment, how long of a span are we looking at?
It depends on the protocol. A lot of the single agent, like solitary one drug protocols for a lot of diseases are maybe every 2 or 3 weeks, maybe for 5, maybe 6 doses at most. So you're talking about a time frame of about 15 weeks total, so about 3-4 months. Lymphoma is probably one of the more intense protocols. CHOP is pretty intense. Everybody does it differently, but it's about the standard CHOP that's out there is about 25 weeks in duration, so it's about 6 months. It's like 16 treatments over 6 months, which is a lot. And some of the treatments are weekly. Some of the treatments later on are every other week. There are so many oncologists in the US and everybody does things slightly differently. I'm a 25-week person. I know people who do 19 weeks. All you're doing is cutting out some of the off weeks and just doing it more intensely along the way. So it's just shorter. So I think all that ends up being about the same in terms of survival time. It just sometimes shortens the duration of treatment. That's probably the longest treatment we do. Some treatments, there's some oral chemo options for patients. So there's a drug called Palladia that people use for mast cell disease pretty commonly. And it's a pill that's like 3 times a week, Monday, Wednesday, Friday, given at home. And in those cases, you recheck them less frequently, like every 6 weeks, but sometimes you're treating longer, like 6 months or more. So some treatments are more chronic, especially the oral stuff, but a lot of the upfront injectable drugs are either every 3 weeks or weekly if you're doing a really intense like multi-agent protocol.
Okay. The one thing I don't think we really talked about was radiation therapy.
The only thing I would say about radiation is I think the side effects are more inevitable. Radiation side effects are real. Like I think particularly the more intensely you treat, they're inevitable. It's not a question of if, it's a question of how severe and how do you manage them. Most of them, though, I would say are usually pretty mild, often not quality of life altering. But I think some of the hesitations with radiation come from side effects. I think some of the hesitation with radiation come from the fact that we have to do general anesthesia on our patients for treatment.
Okay.
Being under for treatment is a big change versus chemo. We don't really need anesthesia a lot of the time. I think maybe I've anesthetized like 1 or 2 patients my entire career for chemotherapy, and they were like not the greatest cats in the world, but I'd never had to do it for a dog. But in radiation, you have to. There's no way you can put them in a room by themselves on a table and expect them to be perfectly still for treatment. You don't want to miss what you're treating, especially with the amount of money you're putting into treatment. The other forgotten thing is you also need usually CT or CAT scans to plan treatment, and that's anesthesia too. So, if you're doing 15 to 20 anesthetic events and then a CT on top of that, it's a lot to do. I think they do well. I do. I think they're not under very long. I don't think they're as groggy. I don't think their recovery is a lot shorter. They're treated on an outpatient basis, and I think they generally do well. But there is a risk. There is a risk, but I think the side effects are there. The radiation oncologists I've known in my career tend to use drugs like prednisone and stuff like that to subvert side effects. So there's definitely like options for side effects in terms of treatment. But I think the goal with radiation is the same goal with chemo: quality of life.
Yes.
It's just there's more of an intensity about it, I would say sometimes. I don't think there's a lot of difference between radiation and people and radiation and dogs. I don't think the side effects are as severe. I don't think the protocols, I've seen protocols in people that are like months in duration, like tons of treatments over like months, versus like the longest one for us is like 3 or 4 weeks. So it's certainly not as intensely like duration wise as long, but the side effects we see can be similar, and that matters. The only really stark difference that I'm aware of is in people, if you radiate the head and neck, there's a lot of issues with producing saliva and digestion of food and swallowing and things like that. Dogs and cats have a significant amount of salivary tissue in their head and neck, so the risk of dry mouth in those issues is really rare. So that's at least one thing we don't have to worry about as commonly, versus in human medicine, it's a huge deal for quality of life.
If this episode helped you feel a little less alone or a little more informed, that's exactly what it was meant to do. In part 2, we will dive deeper into quality of life, what to watch for at home, the hardest conversations families face when treatment stops working, and ultimately, what gives Dr. Renaldo hope in his field. You won't want to miss it. Thank you for listening to Did You Know? Is there something about Partner that you want to know? Email us at letstalk@partnervesc.com. Who knows, we might turn your question into an entire episode. You can now find us wherever you listen to all of your other favorite podcasts. Subscribe now.